Our next speaker, it's part of a, or he's been leading a group developing a very interesting algorithm to guide in the decision-making process for patients that might qualify for these particular kind of therapies. It's important to know that our next speaker is a family medicine trained physician, but also have respiratory medicine kind of training. So he has been dealing with respiratory disorders in the primary care setting for years. He's been an author of several manuscripts and scientific articles, one of which is right now under revision that all the participants eventually will get to help you in your daily practice. He's been the chairperson of the Family Physician Airways Group in Canada, and he is the current chairperson. He's been a member or chaired multiple scientific conferences, more than I can name here. And a very interesting fact about our next speaker, Dr. Alan Kaplan, is that we've been talking about allergens and mites, and we also recognize that dandruff of animals, it's one of those allergens. But Dr. Kaplan is not willing to take his dogs out of the house. But it's something that canine lovers like me happen to have. But without further ado, I'm allowing the floor to Dr. Alan Kaplan from Canada.
Marcos, thank you very much. And you're right, we have 4 dogs. And the irony to that, Marco, is that my oldest daughter is actually panallergic. She's got asthma. And we solved that by building another house on our property for her to live in. So she actually, we still have the dogs in our house and she's able to live with us still as well. So really, it's a real pleasure to join all of you in Florida. I just, as you can see from my backdrop, what it looks like here. I'm from just outside Toronto, and we have snow, and it's very, very cold now. We're in a very significant cold snap. So my only regret to all this, and I told this to Marco, is that we're not doing this in person, so I couldn't come down to the warm weather of Florida to have this talk with you. But we're going to talk about this, and I have the luxury now of having listened to a bunch of wonderful, informed speakers with a lot of passion about the topic, and I get to sort of to put all this together into a practical primary care package for all of us. So I'm going to go back and delve into where we've come from a little bit. Talking about allergic rhinitis, can talk about asthma as well. When we should consider immunotherapy and review all those things we talked about, and then end this by talking about how we in primary care can, and I'll say should, manage these patients. So I saw in the paper, this is last year, about how bad allergic rhinitis were, and I think that's really a significant issue of how significant our patients are suffering. So here's my disclosures. I work with a lot of different companies that make respiratory products, and I have some pain interests as well. ALK is the allergen, is the immunotherapy company I work with, and thank them for their sponsorship. I'm also involved in a variety of Health Canada resources, and I'm involved in things in the United States as well. I've been down as a speaker to Pri-Med many, many times over the years, and I'm currently involved in a program called Conquest, which is involving COPD management across 4 healthcare systems in the United States. So it's a great opportunity for me to come and talk to my American colleagues, and I appreciate that opportunity. Well, I think the first thing we have to talk about, if we're going to talk about allergic rhinitis, is the concept here that we have to make sure the diagnosis is correct. So people come in with a stuffy nose, and the first question, is it allergy at all? So one of my colleagues in the group, Tony Chavarella, and I worked on this program. We kind of like mnemonics. So this is a differential diagnosis tool for rhinosinusitis. And by the way, all these tools are available on fpagc.com. This is the website for the Family Physician Airways Group of Canada. And we're a group of primary care docs with really an interest in trying to improve respiratory management across the country. And of course, allergy management and allergic conditions is a big part of that. You are more than welcome to join up as American clinicians. It doesn't cost anything. You're welcome to have us. You're welcome to use our tools. And so feel free to have a look at the site. So in terms of this mnemonic, in terms of allergic rhinitis, we call that soiree. Again, there is French in Canada, and I don't speak that much French, but still. So sneezing, obstruction, itch, rhinorrhea, and itchy watery eyes. And these classifications, you're all familiar with those symptoms of allergic rhinitis and allergic rhinoconjunctivitis. Things that are usually not associated, we talk about the PODS, where this is more infection. So facial pain and pressure nasal obstruction, which of course can be in both, but nasal purulence. You don't get purulent secretions very often in allergic disease. Now, as you know, green color is related to breakdown products of white blood cells in sputum and even nasal discharge. So it can be occasionally happen in allergic symptoms, but it's less common. And when you're so congested that you can't smell, there's something more going on. And there can be a great number of things that can be causing that lack of smell. So usually, I guess someone maybe has symptoms of allergic rhinitis and may be congested and maybe drippy, but usually it's not so bad they can't smell anything at all. So again, we're thinking about rhinosinusitis. We're thinking about viral versus bacterial. I was involved in a guideline where we looked at how, when you should treat rhinosinusitis with antibiotics. And really, we talked about the fact that it should be after about 7 days of symptoms before you actually give an antibiotic, because we want to decrease unnecessary antibiotics. But I think the danger signs are important. I'm going to come back and talk about those in just a minute. But you can see here that there is a bit of a differential diagnosis. So before we just assume everything that it's a stuffy nose is going to be allergy, and as our speaker talked about using inhaled steroids, that may not be the right answer for everything there, but of course it's a very useful product. So red flags are important. I think the way to do that is to look in the nose. So we talk about if the symptoms are unilateral. Again, usually allergic rhinitis is going to be bilateral. It may move back and forth from one side to the other, but if it's persistently unilateral, please have concerns about that. Is it a polyp, which of course can be bilateral as well? Is it an infection? Is it a foreign body? You especially see that with little children. They tend to stick things in their nose. It's hard to see that. And of course, you have to think about things like cancer and, thinking about an older Asian population, you think about nasopharyngeal carcinoma, for instance, you don't want to miss that. Recurrent epistaxis, again, you can get bleeding with allergic rhinitis with enough blowing and enough use of nasal steroids, which can thin the septum. You know that when you give nasal steroids, you want to use the crossed arm method. So what you want to do here is you want to spray it in this direction and in this direction, because you want to spray away from the septum. You don't want to spray onto the septum. That increases the risk of thinning and bleeding. So again, you're concerned about medications that can cause rhinitis, and alpha blockers are a significant example of that. If you have bleeding, you're thinking about hematologic disorders. And I have actually picked up a leukemia that presented with epistaxis. And I don't know why I did the CBC on this young man when I saw him emerge. But again, that was a situation. And of course, I've talked about foreign bodies and so on. So here's a tool that maybe none of you know where it is in your office, the nasal speculum. If you can pull it out, you should have a look up there to do that. It's a very useful tool. You can see a little higher. You may see something like this. So you may see something like this. Now, on the top, on this one here, that's going to be a swollen turbinate. That's going to be more consistent with allergy. If you see something like this, which is more flesh colored, you're thinking polyp. If you're brave enough to poke this with a little probe, this one on the bottom will not hurt. Well, this one on the top will hurt a lot and it'll hit you. So don't do that. But a polyp is insensate, and that gives you an idea of what it is. And this is nice and usually smooth. It could be a bit irregular. It's going to be a slightly different color than the turbinates around. It gives you an idea of the polyps. If you don't have a nasal speculum, you can use your otoscope. You may want to throw out the plastic piece in between patients. That's all. So allergic rhinitis sufferers suffer a lot. And while I started off showing a newspaper article saying it's really bothering people, most people with allergic rhinitis suffer in silence. And they do that because they've already used things over the counter. They've already used antihistamines. You can buy nasal steroids over the counter. You may have given them these prescriptions in the past, and they've helped a little bit, but they haven't helped a lot. And they got tired of coming back and complaining. So they just have all these symptoms constantly. And the obvious ones are the itch. Everything okay? The itchy eyes, the blocked nose, the difficulty breathing, the runny nose and sneezing. But then it affects daily activities and causes things like fatigue and decreases ability to do things outdoor because of the congestion that happens. So in terms of classification, I'm just reviewing this quickly because we've talked a little bit about all these things. We talk about an intermittent versus persistent. Intermittent happens not every single day, whereas persistence happening every single day of the week for a month in a row. And then we break it down to mild, which is not as common, it's not affecting sleep or activities or work or school, versus moderate severe, where their life is significantly affected in the things that they're doing. So this is just a quick breakdown for that. But obviously, the treatments we're going to use may be a little different depending on the severity and the persistence of the symptoms. The next thing we break it down to is whether it's seasonal or perennial. And there's a few reasons for that. Number one, because seasonal treatment requires treatment just during the season. As you might imagine, the common things are tree grass and ragweed, as all has been talked about already. And there's seasonal things that occur, and the seasons are going to be slightly different depending on where you live, north and south, and where you live east and west. These things are all going to be changing. So I'll be giving some ideas of what the allergy seasons are, but they can move around. Perennial are the things that are there all year round. So the house dust mite, as Dr. L talked about very, very clearly, is there all the time. Cockroaches are less of a common problem where I live, although in downtown Toronto I concur, but it's a much more common problem in southern United States. Molds are complicated. We have summer molds, we have winter molds. They're mixed by themselves. And of course, we've already talked about the animal dander issue with Marcos initially, that your animals will be living you at home. Now, that doesn't mean that we can't do things about these things. And Frank talked about dust mite preventative things, humidity, vacuuming, washing, freeze them or fry them is the analogy for things like bedding and stuffed animals for children, things like that. And cockroaches you can try to clean. It's hard because it's not indicative of your cleaning if you have cockroach infestation. Animals, you can do things like keep them out of the bedroom of the sufferer. You can have them brushed and washed. If you wash a cat, it works really well for two reasons. It decreases the amount of Fel-D antigen, which they get from their saliva by licking, but also cats hate being washed and they run away. So that solves that problem as well. My tongue is in my cheek, of course. But I want to think about some other things and things that actually people have in their symptoms that we see every day in practice, and they're frustrating. People come in and say, I'm tired, I don't feel well. And they may not even, and they won't recognize that allergic rhinitis is the factor, but the fact they're not sleeping because they're so congested that they're waking up at night. And when they roll over, they get blocked and they can't sleep. So falling asleep is an issue. Fatigue is an issue. It impairs their daytime activities. It decreases their productivity. It makes them frustrated. You get tired enough, it even affects sexual function. But absenteeism and presenteeism is something that we don't often talk about in terms of the cost, but recognize that people are actually missing work because they're so tired, or where they're at work, they're less effective, which may prevent things like promotions and stuff down the road. Then that leads into things in terms of significant effects on examinations. This is a very interesting trial done by Walker that looked at, if you look at kids who have allergic rhinitis and have summer examinations, if they're in summer school and so on, and if you compare allergic rhinitis versus non-allergic rhinitis patients, well, not surprising, the kids who have a rhinitis don't do as well. That's because of the symptoms, because of the medications. Early on, the conversation was talking about antihistamines causing sedation. That's an issue. Of course, you have asthma. That's going to be a whole other problem in this as well in terms of being short of breath. So it's affecting examinations, affecting school performance. And for those children, you want your children to do as best as possible in school and have every opportunity to succeed. But it's more than that. It also includes things like behavior. So emotional problems are higher in those kids with hay fever, higher again, as you can see, than asthma. And it's not, eczema is not an important problem. It is. And people that suffer from eczema are scratching and they're very distracted. It can be very, very disabling. But hay fever seems to be a bigger problem for most of that. But conduct issues and hyperactivity problems, fascinating kind of work that shows that if you get attention deficit disorder between the atopic versus non-topic, it's just about double. And if you look at autism disorder, it's interestingly, it's a little bit less. So not really sure what to do with that. But it seems to be the behavioral stuff more than the underlying cognitive issues. So there you go. Now, we've talked about comorbidity. Kamisha talked about that earlier on. And I think we have to, and talked wonderfully about the ARIA guidelines that really put asthma and allergic rhinitis together. And it's a huge issue. But there's a whole list of things here. And we can let some of them you may not have thought about, like earaches, and chronic tonsillitis, whatever that means, but looking at the sleep issues, especially asthma. And if you look at, and again, the numbers aren't important, we talk about 40% here, but the number with the allergy adults in green, much is higher than the blue and the people who don't have allergy. And if you look at the bottom one, again, it's not that these people who don't have allergy don't have some of these issues. Of course they do, but the patients with allergic disorders have them so much more. As was talked about earlier, also the risk of having chronic inflammation and then infection with sinusitis and ear infections can happen with there as well. So you can see these comorbidities are a really big problem. And I'm going to talk, and GERD is a surprising one for that, but maybe not if you think about the fact that you're congested, you're chronically sort of coughing and doing stuff that's going to increase your intra-abdominal pressure and push acid up into your esophagus and so on. All of that can lead to symptoms. So GERD is a very common comorbidity in allergic rhinitis, also, of course, in asthma and even in COPD. So we're talking about almost 3/4 of our allergic rhinitis patients have comorbidities. So we have to deal with all those issues for a successful patient to encounter. Now, I'm not going to go through all the different treatments because they've already been gone through today. I want to highlight, of course, that antihistamines have usually been tried before the patients come to see us once they realize it's allergies. They may have already used nasal corticosteroids, and the data is very clear that even with these two combined, it's not as good as combination therapy with a topical nasal corticosteroid antihistamine combination. We have two different brands of that in Canada. I'm sorry, I didn't check about United States, how many you've got in the States, Marcos. Maybe you can let us know. But in Canada, it's called Dymista and Ryaltris. Combination of steroid and antihistamine topically is far and away the best combination for medication for that, better than antihistamine and nasal steroids with oral antihistamines. Nasal antihistamine alone, again, not quite as good. LTRAs are used as a third or fourth line treatment. They're useful for people with concomitant asthma, of course, but they're not a very strong asthma medication, as you all know, and they do have some issues. The FDA has made rules, has made recommendations to be careful of that in children because of suicidal thoughts and neurocognitive issues that have occurred with leukotriene receptor antagonists like Singulair or Montelukast as an example. I haven't seen that very often, but I have seen a couple of kids who get a little depressed with it. So you got to be careful. And if you are using LTRAs, please make sure to make people to know that if their mood starts to change, they should be in contact. Obviously, there's surgical things for things like polyps that come back, and Frank did talk about biologics, and the advent of biologics, especially the anti-IL-4/13 dupilumab, has gone wonders to actually decrease the polyps and decrease the number of surgeries that are required because they shrink down those polyps. And some of the newer therapies like IL-5s and anti-TSLPs probably have similar, if maybe not quite as good efficacy for that. So we're left with the combination about immunotherapy. So this is more of a review to bring us to the spot about immunotherapy. But before I get there, I want to remind you about something because we've been using first generation antihistamines for a long time, and now we have a bunch of better ones, right? So please, if you're using first generation antihistamines, and I know that they're attractive to use because they're sedating, right? So you use them at nighttime when people sleep, but actually they don't cause good sleep. They affect the sleep cycle. You don't get into deep stage 3 and 4 and REM sleep. You actually have very superficial sleep. You're fatigued the next day, morning after. It impairs your learning and memory and reduces efficiency. So please don't use first generation sedating antihistamines anymore. Use the second and third line antihistamines. It causes sedation. It causes anticholinergic effects, which actually Benadryl, as an example, can be used for as an anticholinergic for someone who has an extrapyramidal crisis. Cogentin's probably better, but this actually works very nicely if you can't get Cogentin. It causes appetite and weight gain in serotonergic. It affects alpha receptors and cause postural hypotension. It can actually even affect QT intervals, and you know how significant a problem that can be. So my message as far as this, and I'm not dissing any particular drug, it's all first generation antihistamines, but Benadryl is far and away the most common. I have nothing against Benadryl, except it's not a very good antihistamine. And the Canadian Society for Allergy and Clinical Immunology, as well as our Family Physician Network Group of Canada, have put out advisories that we should no longer be using Benadryl as an antihistamine. And I would include Atarax in that as well. So use the newer ones. We have some wonderful new antihistamines that are prescriptions that are quite effective. Okay, immunotherapy. Why am I talking about immunotherapy? Well, I think that we need to offer this treatment with people who don't have adequate response to pharmacotherapy. And of course, they should have used the environmental controls, but even if they still have the dog at home to carry on that particular discussion, I think we still should be trying to do something about that. And I think the benefits are clearly there for improving symptoms, decreasing the need for pharmacotherapy. I'm going to show you a little bit of data about preventing asthma and improving asthma, as well as other comorbidities. There are downsides, of course. We've already talked about needles and cost, and Frank talked about, and people don't want to have reactions, and anaphylaxis is a concern. The treatment frequency, having to come to the office if it's subcutaneous immunotherapy, people don't like needles particularly, and it doesn't work right away, as has been mentioned by a couple of previous speakers. There is a lag, but it does work within the first season. I'm going to show you a little bit of data about that. So I think it is something that we can say we can even promise to get some benefit in the first year, but I'm going to come back to that. So again, this has been talked about as well. A very quick summary. What happens here, you take your allergen, it goes through the membrane and is grabbed on by the antigen, the antigen presenting cell, which then stimulates the T cell system. T cells, through those cytokines we talked about, IL-13, 4, and 5, then promote B cell production, creating plasma cells, which then release antibodies. So the antibodies are IgE. So those IgE antibodies float around. And as you recall, if the allergen comes into the body and the IgE molecule grabs it, it becomes a complex. And that complex then goes to the mast cell, and the mast cell releases a whole bunch of vasoactive properties like histamine. But it's not just histamine, which is why antihistamines don't work completely by themselves. It also releases serotonin, leukotrienes, and a bunch of other mediators, which cause the swelling, itchiness, congestion that occur in the eyes, ears, and of course, nose, and of course, even the lung. So one of our biologics is an anti-IgE. So an anti-IgE, it blocks the IgE, and therefore, when the allergen comes into the body, it doesn't even cause the reaction. And anti-IgEs are used for people with urticaria, and they're an older asthma biologic as well. We've also mentioned the asthma biologics that get used in this stage here to prevent the entire response from occurring. They work up higher up in the chain. And there's even higher ones that work up here called TSLP, which work on the epithelial level. That's fine. We're not in primary care going to be prescribing biologics unless you have a special interest, in which case then reach out to me. I'm happy to discuss this with you. But I think it's important for us to know in asthma who you should consider referring. And I know that's a bit off topic where we are now, but if you have asthma, who should we consider referring? Someone with their current prednisone prescriptions, people who can't get control despite doing everything right. They're taking their medicine, they're taking it regularly. Their inhaler technique is good. You've dealt with the comorbidities, you've dealt with the triggers as best you can. Biologics, but they cost upwards of $25,000 a year. They're expensive, but they're so terribly effective, and they change people's lives. And you don't want people to have recurrent prednisone prescriptions. That cortisone load is bad for them. Once you hit over a gram lifetime, and certainly 2 grams, we have all kinds of risks of prednisone, as you're all familiar with, like fractures and diabetes and bad infections, like pneumonias and non-tuberculous mycobacteria and even TB. So a whole list of things that can happen. So what are we trying to do with all this stuff? Then we've broken down, here's what happens. That's the cascade. What do? Well, we give immunotherapy. And immunotherapy works through a similar mechanisms, but instead of IgE being produced because of that slow, relentless, regular giving of the antigen, if you give too much too fast, you stimulate this system. But slowly and regularly, we actually change this to IgG. So then when the allergen comes into the body, it gets met up by the IgG, which takes it away, which is fine. It doesn't evoke that entire response with causing all the symptoms that we've been talking about all day. So the symptomatic medications, yes, there's not a lot of risk of systemic events. And by that, I mean anaphylaxis. We got lots of different choices. A lot of it you can buy over the counter, which is attractive to patients, especially when healthcare is so expensive. Immunotherapy, it's actually going to induce an immunologic response, which means it's going to have a persistent effect during and after the end of the treatment. It will decrease the use of medications. It will help the development of some of those comorbidities. I'll come back to that. Of course, it is prescription. It's not inexpensive, but it may actually also, by turning down the whole immune system, prevent the onset of new allergies. So all of this is important. And of course, they both are going to reduce symptoms, but we want more than that with immunotherapy. So we can continue doing what we're doing with symptomatic therapy and get a partial response. Occasionally, if it's a complete response, the conversation's done. Partial response, it's time to move a little bit more. So here is looking at the relative difference, and again, this is total nasal symptom score of sublingual therapy versus pharmacotherapies, right? So a whole bunch, some meta-analysis of a bunch of studies. Okay, so you can see montelukast is not terribly effective. You can see that oral antihistamine, one that's used very commonly, again, its effect. Nasal spray does a lot better. But you can see that sublingual immunotherapy in this particular study was much more effective for symptoms in the first year than using these symptomatic therapies we use every day. So it's not just a matter of trying to cure the condition, which I want to do. I also want to decrease symptoms on a regular basis. And it doesn't mean you can't add it to these things and get a synergistic effect, and you certainly are going to have that. So this is the kind of things that happen when you use, this is sublingual immunotherapy data I'm showing you. But again, it's similar for subcutaneous therapy. I'm going to emphasize a little more on sublingual therapy because most of us are not going to be doing skin testing, and I'm going to come back to that, and therefore prescribing subcutaneous therapy directly. But you can if you feel comfortable. But you're seeing here the significant benefit of immunotherapy for both grass and ragweed very early on within the first year. And very significant. I mean, look at the numbers you get in terms of the ragweed reduction. 70% reduction in watery eyes and itchy eyes. Those eye symptoms can be very disabling. Yes, we have eye drops we can give people, antihistamine, sodium glycate combination, but certainly nice not to have to put drops in your eyes. Now, how fast does it work? Well, you're actually seeing that within 8 weeks, you're actually getting a benefit, and this is total nasal symptom score measurements with subcutaneous immunotherapy. And that number continues to increase. By a half a year, you're up to 50% in this particular practice study. Obviously, there's different studies with different numbers, but you're getting an idea that you're getting improvement very early on within a couple months, and certainly continued improvement. If you take that out to a year, it's even higher. So, if you're getting a 50% better reduction compared to placebo, you're seeing a very effective relief at 8 weeks, and therefore is what you want. Now, Frank touched on this, which is better, subcutaneous or sublingual immunotherapy. So let's just chat a tiny little bit about that. The bottom line, do you think one is better functionally? Is it better than the other? We've always believed that subcutaneous, since it's given by the allergist, we're giving a needle, must be better. It must be a better thing right into the system. In fact, if you look at this Cochrane analysis, you know what Cochrane does? They take all the data and synthesize it to see, and they make comparisons like this. So if you have interesting questions, look it up on Cochrane. They've often looked at these questions for us. And the bottom line, I don't have to get into all detail, but whether you look at symptom scores or medication scores, whether it's seasonal or perennial, sublingual for subcutaneous, they both work. They're both to the negative side of the zero line, and they're very, very effective. Subcutaneous may actually not be quite as good for perennial as sublingual, interestingly. So we'll have to have a look closer at that. But the bottom line is they both work, and I'm not recommending one over the other because of efficacy. What about how soon they work again? This is, again, looking at a study for a grass pollen. Again, it's a sublingual study, but you can see they give sublingual immunotherapy versus placebo, and they looked at this in the course of the season, and a 50% reduction in 50% improvement in the number of well days, which worked out to be 43 days across that symptom versus 34 for placebo. So again, it's working in the first season, because that's a misnomer. People say, well, I have to wait too long for immunotherapy to work. No, there's going to be benefit in the first year. And if you don't get benefit, I'll come back to this, you'll want to ask some questions why they've had no benefit at all. So the other side, of course, is the safety. I mean, we have to be concerned about that. So are people going to have reactions? And this, again, I'm going to talk about sublingual. Subcutaneous, you're familiar with that. People can have anything from a reaction locally in the arm, which has already been shown very lovely by our second speaker, showed that, an idea of different wheels that can occur and reactions. They can be more significant. We're developing a more widespread systemic reaction and even full-blown anaphylaxis from subcutaneous therapy. Sublingual therapy is much less common. There's no cases of anaphylactic shock. There are now cases of anaphylaxtoid reactions where people end up using epinephrine, with significant swelling of the face and maybe a little tightness in the throat, which causes people to be afraid. And therefore, I would use epinephrine if you're worried. But really, probably most of the people didn't need epinephrine. They just needed some time. And a single dose of epinephrine was used. There was no bounce back in these people at all. So it's a very safe therapy. And it doesn't matter whether it's adults or children. And interestingly, even if they have asthma, the risk is not higher. So a number of different studies showed here for different immunotherapy. And there's mild reactions, and I'll show you some of those in a little bit. But really, as a most part, these things are not very significant. Moderate reactions, by the way, will include GI reactions. You'll occasionally get the immune system turned on into the gut as you swallow it after you take your therapy. So that can also be an issue to think about. And they're usually transient. I'll show you that again in a few moments. So we talked about in the first year, but then if you look at what happens over the course of the 3 years, and you need 3 years of therapy for the most part. And it's interesting for all immunotherapy, it takes time for the immune system to be changed. I mean, as Frank talked about, our environment causing all this. Well, the environment takes time to change our immune system, and it takes time to change the immune system back, to calm it down, to switch it from IgE to IgG. So we need at least that 3 years. And some people do very well a little sooner. Most people take at least 3 years. Some people take longer. So I'll continue for longer than 3 years if they had a partial but incomplete response. So I'm fortunate. I've been doing allergy tests. I'm a family doc. I should give you an idea of that. I'm a family doc, but I obviously have a respiratory expertise. I get consultations from my colleagues, and I've been doing a lot of this for a long time. I did used to do allergy testing, skin testing in my office, but then we got an allergist in the office, so I wasn't going to compete with her. So she does that. But I'll still do some of these other things that we talked about today. So I've been doing this for years and giving both subcutaneous and now sublingual immunotherapy for many, many years. So you can do this in your practice. There's no reason why a primary care practitioner can not do this. You were taught very nicely how to do that earlier on in the program. Just make sure that you have all the safety mechanisms there, especially having epinephrine available. So it's a 3-year program at least. Does it work for asthma? I want to point out this is a study from 1961. Probably predates many of you on the call. And what you saw here in the people at the highest tolerated group was children. The number of kids that had wheezing and wheezing with upper respiratory illness compared to the control group was significantly reduced. So we've known this since the 60s that immunotherapy works for asthma, but we don't generally talk a lot about it for asthma. Well, this is the GAP trial, and this is an incredible trial that really showed in children with allergic rhinitis. So they didn't have asthma, and they were started on sublingual therapy versus placebo. And then they looked at these children as they got older, and the number of children that developed asthma in this were much, much smaller. Less symptoms, less medication, less lung function effects, as you can see as well. So immunotherapy actually was modifying to the body's immune system such that these children either had less severe asthma if they got asthma, but actually there was less asthma happening in the treatment group than in the placebo group. So isn't that fascinating? If we actually affect the immune system earlier, we can actually prevent the comorbidities. And the worst thing, I think allergic rhinitis is bad, but asthma, in my mind, would be worse. And therefore, we like to prevent something like that. So the message here is immunotherapy in our children with allergic rhinitis. If we get that going early enough, we can modify the entire illness, both for their nose and their lungs. Well, this is the GINA guidelines for asthma. And most guidelines in the world have not emphasized very strongly the use of dust mite therapy. But the explosion of dust mite therapy, especially for house dust mite in asthma, and I'll show you a couple of those articles just as references in further slides, has really then motivated everyone to say, hey, we should be thinking about sublingual therapy for asthma. I've had a look at the most recent asthma guidelines in the United States by Cloutier. Didn't talk very much about that. Our Canadian guidelines barely mention them. So, but GINA, which is a recommendation around the world, they've actually talked about that. So they talk about not maybe so much in step 1, although I think maybe we should be talking about this in people with very mild asthma as well, if they have concomitant allergic rhinitis. But for the asthma itself, as you step up to regular use of inhaled steroids or needing more, house dust mite sublingual immunotherapy is added in by GINA as a recommendation, not so much in step 5. Step 5 are those people that require the biologics. They've needed oral steroids a lot. They're on every single medication. These people need to get well controlled before we can start considering adding on something else, to stimulate their immune system. So not so much for this group. So it's not an add-on at the end, everything else when nothing else has worked. It's adding on at these stages here, okay, to make sure that we actually can minimize the use of inhaled steroids, the amount of medications they need. And I'll show you that, because even the regular use of inhaled steroids has potential adverse effects. So we want to use the least amount of medication to get people the most controls possible. So the rules are, if using an asthma, a couple things. The studies that they did, in Virchow and Christian's study here, the top one of the big ones there, talked about using this in asthmatics. Maybe they weren't completely controlled, but they weren't sick asthmatics. Their FEV1 was not less than 70. They hadn't had a recent hospitalization, hadn't had a recent prednisone use. All right, so that makes sense. If they're uncontrolled gently, like they're using a little bit too much more Ventolin or salbutamol or albuterol than you're happy with, then okay. But if they're still stepping up on their therapies and you don't know which direction they're going, you probably should not be starting immunotherapy at that stage, because you don't want to stimulate an immune system that's also turned on. It's useful, I'll show you this in a moment, to allow ICS reduction so we can lower the dose. And there's even now the biologics are being added to immunotherapy, and the mixture is now being used by the specialists. That's going to be outside most of our experience as primary care docs. But being on a biologic does not necessarily mean not to use immunotherapy or to stop immunotherapy. And what's interesting about the asthma biologics is they deal with the whole body. So while they work, they're there for asthma, they're usually going to work for allergic symptoms as well, such as atopic dermatitis, which the IL-5s and the IL-4/13s work for very nicely, and the allergic rhinitis, which all the biologics work very nicely for, and the polyps, which most of them help for. So there's a nice concomitant synergism there. So this trial, again, by Christian Virchow, showed that what they did, they gave, again, 2 doses of house dust mite sublingual therapy. But what they did was they reduced the ICS over the course of this of this 6-month trial, and the first 3 months here, and then the next 6 months here, and they looked to compare to placebo. So they were doing a reduction in the ICS dose of these asthmatics who were stable going in, and they were reduced. So what you would expect if you reduce ICS is a certain number of them are going to have exacerbations because they needed to be on that dose, and the rest of them didn't need to be on that dose, but fine. But you can see those people on house dust mite therapy had less, not none exacerbations, but had much less exacerbations. And if you persist that out to 6 months, those lines continue to be different. And yes, there's a few more exacerbations because of that, but also they stepped this up to a complete reduction. So they went to a 50% reduction, they had exacerbation, and then they continued to stop all the ICS, which is something that's dangerous. And I don't know how they got ethical permission to do this trial, but again, he's in Germany, good, I don't know. And by that, they actually had a lot more exacerbations in the placebo group, and some exacerbations in the treatment dose, but you can see the significant difference. So the point being here is that if we use immunotherapy, we may also be able to reduce, if not stop, but be very cautious about that, our asthma therapies. So how does this stuff work? We've touched on this a little bit. It's a sublingual tablet. It goes underneath the tongue once a day. It's a very fast dissolving. It's lyophilized, which is how that works. And that solubilized, it's a tough word, solubilized allergen then interacts with that antigen presenting cell that I showed you earlier in the oral mucosa. Right? So the timing of this is important because obviously for things that are perennial, we do it all year round. Whoops. For people that are having it seasonal, then we are going to use it pre-season. Now, the dates of this are going to be a little different depending where we are. This is the timing for what I would use in Ontario. It's going to be a little bit different for you. I'm going to show you that in just a minute. Trees start earlier than grasses. And obviously ragweed, which is the end of the summer for most of us, starts a little bit later. You start a little bit pre-seasonal before the actually pollen is there. As you can see, that's the white check marks. And then you continue it during the entire season, and you stop it at the end of the season. So the concept here is you start it pre-seasonal to get the body prepared for it, and then you continue through the entire season, stopping it afterwards. That means you're on this for quite a number of months, at least 6 months for grasses, 6 to 7 months for ragweed, depending where, and again, 6 to 7 months for trees. So you can see, or 6 to 8 months for trees. So you're on this for a long time, but it's easy to take because you're taking this at home. The first dose you do in the office, so the patient's there. Am I doing it because I'm worried about anaphylaxis? Not really. I'm doing this because if patients get reactions, I want to be able to reassure them. I'm going to show you about that later. Now, if you compare patients' preference for immunotherapy for sublingual and subcutaneous, then the reality is most patients prefer sublingual therapy, significantly higher. And not surprising. I can take a tablet. Now, you should point out that picture. It's the best I could find. That tablet's on top of the tongue. That's the wrong way to take it. It's under the tongue. It's sublingual, so don't do it that way, please. All right. And of course, the injection to Bart Simpson there, he's not going to be great about that. So these are patients that had allergens for a long time. Some of them, of course, it was brand new, but you can see clearly, if we're talking about what our patients prefer, they'd prefer to have immunotherapy that they can have not in a needle. They can actually take themselves at home and not have to make time to come to the doctor's office. Is sublingual immunotherapy a little more expensive than subcutaneous? Usually. So that's going to be a barrier as well for some people. And it's not available for every single allergen. And we'll talk about that. So what should we do in family practice? In primary care, as a non-allergist, do we have to just refer everyone? Well, you heard Frank say quite clearly earlier, that would, that'd be great from the point of view of the finances of the allergists in our countries, but there's just not enough of them. They can't possibly keep up with the demand. And the algorithm that I'm going to show you shortly, I just presented at our Canadian Society of Allergy Clinical Immunology, and it was created with some allergists in our country. But I expected to get a lot of pushback about the concept of primary care initiating immunotherapy. And I was flabbergasted by the fact that every single allergist that came up to look at the poster said, thank you, because I don't have time and the space to see all these people with just allergic rhinitis. I have sicker people that I need to see, but I have to see these people with allergic rhinitis because I have to get immunotherapy. But if you can do it, that's going to allow me to see sicker people that I need to see. It was really very gratifying. Anyhow, what can we do? We can make a diagnosis. We've talked about that. We can treat symptoms. Well, we're already doing that. We can consider immunotherapy, but here's where my rub is. Please, earlier. Okay, let's start thinking about this. I know we haven't, because that means a referral to the allergist, because they're very mystical, the allergists. And no offense to my colleagues on the line, but they've kept this as a very mysterious thing that primary care can't do this. You don't understand the immunology well enough, and we don't. So we have to be clear about who we can safely treat and not. And I'm going to come back to that. But we have to start thinking about doing this earlier. And we can do this on our own. I'll show you how. A cure versus a treatment. If I can change the body's immune system to no longer be an IgE-driven system and decrease those cytokines, can we actually get rid of the symptoms entirely? Okay. Can we do allergy testing in primary care? I've touched upon this. You can. Again, you have to be comfortable. And certainly there's many primary care docs that do this across both of our countries, as long as you can do it safely and know what you're doing. If testing is not available, we've talked about some of the people you can't do it on. For instance, if they're pregnant, if they got skin conditions, and so on, if they've been on antihistamines or other medications you can't stop, then consider serum Ig testing. Know what's available in terms of testing. The testing parameters are different in our countries. They're different in our provinces across Canada. The difference across the states and your healthcare systems and your plans across where you are now. What's available? What's the cost to the patients for you as well? Subcutaneous versus sublingual. Obviously, we've talked a little bit about that already. If you're going to give sublingual immunotherapy, you give the first dose in your office. That's a must. In theory, because of the risk of anaphylaxis. Again, I've never seen one. Speaking to a whole bunch of allergists, which I did in October at that meeting, I had one doctor come say, I had one person that I had to give epinephrine. I probably didn't need to use it, but she was getting very tight in her throat. I figured it was safer. Completely agree. If you are giving subcutaneous shots, then you've got to be prepared for anaphylaxis. Okay, please be ready. Have epinephrine. Have either a vial or have a device, whether it's EpiPen or Allerjet or Emerade, whichever ones you have epinephrine around. Because if you give an allergy shot and you don't have epinephrine and the patient has anaphylaxis, I'm sorry, you're going to have a lawsuit. I know lawsuits are a bigger problem in your country than mine, but I say the same thing to everywhere I go, including in Europe. You do not want to have somebody do poorly with anaphylaxis. Even if they do okay, you were not prepared. And if they die, God forbid, then obviously that's the worst thing you can have happen to have in your patients. And we know that the delay of introduction of epinephrine is one of the biggest reasons why people don't do well with anaphylaxis. So we don't want our patients to die. And if they don't die, we don't want them to sue us afterwards. Okay. Now, sometimes this sublingual therapy has been started by the allergist. And the patient says, well, can you just reorder it for me? Because I don't want to go back to the allergist because it costs me money, or they don't want to go in my country because we have universal health care. In your situation, it may have to charge them for copays, or they may not have coverage. So please just go ahead and reorder what they've already been on. Okay, and do that for the next couple of years. That is a safe thing to do as long as they've had some benefit from the immunotherapy. And just copy what the last one was. You don't have to be inventive. It's not going to be different strengths and so on for sublingual. Subcutaneous, that's a different story. You have to titrate the dose up, as was mentioned. I usually do some retesting after about 3 years. After 3 years, a lot of people's skin tests may change and become negative, in which case you can stop the immunotherapy. Their Ig levels may go down. You can stop immunotherapy. If they're still up, you may consider continuing it, and so on. That's a bit controversial, and it'd be interesting to hear if any of the allergists are still online, how they feel about that. We've talked about beta blockers. It's not that beta blockers cause anaphylaxis. It's that they blunt the effects of epinephrine, and therefore the epinephrine doesn't work as well if you get an anaphylactic episode. So I wouldn't give subcutaneous immunotherapy on beta blockers. I think we have to think about that. Sublingual is probably a bit safer. If you are going to give it, then you want to make sure to have glucagon around. Yes, the same glucagon we give for hypoglycemia, because that actually works on a different mechanism to actually treat the anaphylaxis. Okay, so with all that, a lot of background, how do we then incorporate this into our practices? Let's learn something new. So this is the algorithm I mentioned, and it was created with myself and a group of other family doctors and some allergists and some of the leading allergists in Canada. So maybe that stopped me from getting as much pushback. But again, you've got someone who's symptomatic with allergic rhinitis or allergic conjunctivitis, allergic rhinoconjunctivitis, with or without asthma, I'll come back to. And I think we should get a baseline idea of how people are. Now you can just ask people how they are, or there are particular tools which I'll show you where you can ask these things, right? The red flags I've talked about already. So again, let's make sure we have the right diagnosis first. You don't want to start going down the allergy cascade if it's infectious, if it's a tumor, if it's a hematologic problem, even if it's polyps. because people aren't going to get better with immunotherapy for polyps very quickly. They have to deal with the polyps. So make sure there's no red flags. Okay. Treatment already, we've discussed this. Again, these different treatments that are going to be there. If they have seasonal or perennial, okay, have they been allergy tested in the past? Okay, so that's going to be your first question. Have you ever had allergy testing in the past? Maybe you haven't had immunotherapy, but you had allergy testing done a few years ago. You don't have to reinvent that wheel. So if they've been tested, okay, if they've already on immunotherapy, then reinforce them. And as been mentioned by a few of the speakers, people tend to stop doing it. They stop going back for their therapy. Even on sublingual at home, they stop doing it for a variety of reasons. We all know that adherence is a huge problem in everything we prescribe, and this is going to be no different. So reinforcement of adherence is huge for this. If they never actually started immunotherapy for whatever reason it was, cost issues, they didn't like Frank that day, whatever the reason is going to be, they didn't start it. So you're going to consider immunotherapy. And is it immunotherapy that you can start in your office? Is it going to be sublingual or subcutaneous? We can then talk about that. If they got asthma and they come back, they should be fairly well controlled. I think that it's very, very safe in primary care to initiate sublingual immunotherapy. Subcutaneous has that risk for anaphylaxis, and we're in a medical legal environment. So if you're to give subcutaneous therapy and you're not an allergist or to get anaphylaxis, you'd have some answering to do. I think that we have a lot of allergists who would support you, but we don't want to take those chances. But sublingual, the risk of anaphylaxis is so tiny, it's so safe that why are we not considering to doing that? So again, we've got available tree, grass, ragweed, and house dust mite. We'll talk about what's available where. If you're not sure, make a referral. If you're pretty sure based on the testing you've done, and we had a beautiful talk on the testing done for allergy therapy. You've had IgE levels done that tell you that and reinforce you that. Go right ahead and do it. If we haven't had previous allergy testing, then clinically think about what allergens they may have based on the time of year. Is it perennial? Is it seasonal? What season? And then if you have skin testing availability, go ahead and do it, or do the IgE testing. There are entire panels you can order, as was mentioned. For where I am, I have to order one at a time with the lab, and each one costs $18. So I try to be very specific about the ones I order because I don't want the patient to have to spend a lot of money because it's not covered on a lot of plans. So I'll order very specific ones. But it's amazing how many people are willing to do this. If I'm looking for just ragweed or just tree or just grass or just cat and dog, which is another story that occurs as well, rather than get a bunch of skin pricks and have to take a day off work. So these things happen. If you have a positive testing, go ahead and start prescribing. Okay? But sublingual therapy, as we talked about. So that's all there. I'm going to talk a little about these decision tools there. Again, asthma, they should be controlled. And then we have to review. So I'll talk about how to do that. So the concept here is going to then be, you've done it. How did it work? Okay? So I'll come back and review this all again at the end to reinforce, but that's the steps. All right. So we go back and again, diagnosis is the first step. This is just, again, a review of what we talked about. They've got the symptoms. They don't have red flags. It's impacting their life. And remember to consider those people who the impact is their presenting problem, the fatigue, the sleeplessness, rather than it being related to obvious allergies. Okay. Chronic cough can be allergic rhinitis. And because when you have chronic cough, the most common reasons are going to be postnasal drip or upper airway cough syndrome, or reflux, or things like asthma. So cough can be the persisting thing. I didn't mention that earlier, but it's there. And of course, the timing and so on, we've already talked about. Whether you skin tested or specific IgEs, that then leads you to a fairly firm diagnosis. So how do we review that efficacy that we talked about? So this, I think, should be done annually. As you're reordering the sublingual therapy, you should be sort of asking how you are. Asking how you are means, have you still been using medications? Could you cut back your antihistamines? Could you cut back your nasal spray? Could you cut back from twice a day to once a day? Are you now using it 3 times a week instead of every night? Okay. How are your comorbidities? Okay. By the way, how is the asthma if you've got asthma? If you have nasal polyps, have any difference to that? Although I wouldn't expect that particularly within the first few years. And then the specific tools, which I'll show you in a moment. Then after that 3 years of therapy, then we want to say, okay, it's been improving a little bit every year. Where are we now? Right? You can test or not, which is a bit controversial. You can decide to continue therapy or not with shared decision-making with your patient. That's going to be based on whether they want to, whether they can afford it, whether they think it's working. All those things are going to be an issue. If things are not clear, you're not sure if it's helping enough, you're uncomfortable, any of these steps, any of these years, then refer on to an allergist. And the allergist will be more than happy to see a patient that's been worked up so well, who started therapy, and then they can understand why things didn't perhaps work as well. Maybe there was an allergen that was missed. Maybe there's a concomitant allergen that wasn't being treated, and that was the problem. Maybe the patient's not using their therapy properly. A whole bunch of reasons, but there's certainly value. I'm not saying we should get rid of our allergy colleagues. We need them. We need them for complicated cases. We need them for people that are not doing well to help us understand why. Sometimes a referral to an allergist does nothing more than reinforce the need for adherence, because their message is everything's done right. How many days a week are you actually taking your sublingual tablet? Twice. Well, that's why it's not working. So all this stuff can be part of it. So if you're looking at which therapies to consider for therapy, and we went through this in quite a bit of detail with the allergists that I work with on this, and it's obviously going to differ on the different country and the climates and so on. If it's perennial, you're thinking about house dust mites and pets and potentially mold, but there's different kinds of mold, which is very complicated. I'm going to come back to that. Okay, so we talked about house dust mite. We were shown all the mechanism of that beautifully by Frank earlier. So that is within our bailiwicks, and that is certainly really great. And let's get rid of those things that are eating our flesh, as he said. Now, the good news, they don't eat it while it's on you. They eat the flakes, and you're actually allergic to their poop, which is why things like the dust mite covers and pillow covers make a difference, because you're actually stopping them from getting through. And since you spend, almost a third, if not a half of your life in bed on your pillow, a dust mite cover can go a long way for that. All right. So cats, the recommendation was an allergist referral for this. Cat right now is earlier on in the course. I think there's going to be time down the road, a few years from now, where cat and dog sublingual therapy is going to be within our domain as well. Mold is complicated because of the different types of mold. I'd love to hear from our allergists. They're still on to talk about this, but there's different molds in the summer. There's winter molds under the snow. I know you don't have that problem in Florida, but I have to worry about that. So these are all things there. I think a referral is there. But if you have a good idea of the season that's starting, very early in the spring, you're thinking tree. A little later in the spring, you're thinking grasses. Late in the summer, the first freeze, ragweed. Fairly regular for that. Even no matter where you are, you can think about the different immunotherapies. So this sort of makes sense, and you can order the IgE for it and consider the immunotherapy. So this is the rhinitis control assessment test. You can use this if you want. I'm giving you it for information. I'm not suggesting you must use this by any reason, but it is a very nice thing. It gives you a score. So more and more in my practice, I'm using scoring systems because say, well, last year you were a 25 and now you're a 16. That makes a difference, even if they say, well, I still need medicine, right? So how often did you have nasal congestion? How often did you sneeze? How often did you have watery eyes? How much did it affect your sleep? Did it affect your activities? And how well was your overall symptoms controlled as an overall picture? If it's 21 or more, then they've got pretty significant symptoms, and the minimally clinically important difference is 3 points. So if you have 3-point difference, then you've made a difference with the treatments. That's the rhinitis control assessment test, and you can certainly download it online. Something simpler, which is kind of nice, is just a visual analog scale. You all use this for other things like pain and mood and all kinds of stuff. Where were you last year? I was a 10. Where are you now? I'm a 7. Good. That's better, right? So it's very simple. You can do that. You can do it for the nose. You can do it for the eyes. You can do it all together. You can do it separately, whatever. But I think it's kind of important to measure something, not just say, how are you? How are you is a little bit vague, and you may miss some things with that. So more and more, I've actually been going back to using this tool, and I keep it in the EMR and I look at it from the year before. I don't show it to them before they fill it out the next year, and then I compare the numbers. And then if it's really not different, I say, well, first I go back to things like adherence and technique. And then I say, well, wait a minute, it's not different. Why is that not different? And then maybe referral is necessary. Right? Now in Canada, we have 5 different choices. We have one for trees, which you don't have. So I'll move off this one to what's more relevant to happening in the United States. And if I'm incorrect, this is what I could find in my research. If I'm incorrect, please let me know, my American colleagues. But you have GrassTech for grass, you have Ragwitech for ragweed, you have Odactra for the house dust mite. And again, here's the timing of it, maybe a little different than what I showed earlier. It's going to depend a little bit on the time of year, so you have to know that where it's going to be. But basically, you start pre-season for the grass and the ragweed, and all year round for the dust mite. Now, this was touched on by Frank earlier, but when you're going to go through this, the first step is set up expectations, and expectations for what they can expect down the road, but also what's going to happen in their first few doses. I expect you to get a little potential swelling under your tongue, a little tingling in your tongue a little tingling in your lips. And someone who's had anaphylaxis before, that will scare the crap out of them because they know that's anaphylaxis coming. But it's not anaphylaxis with sublingual therapy virtually ever. And just observation for these is fine. So therefore, if they expect it, they're not going to freak out. Give them the first dose and watch them at least a half an hour, maybe even a little longer. And if they have a reaction, bring them back the next day for the next dose. If not, they can take the rest at home, which they'll be very happy about. I watch them for at least a half an hour and longer if they have symptoms. But if they have no symptoms, I shoot them out. But they have to stay a half hour. That's part of the deal. The first dose, you got to stay for half an hour. And with that, I'm going back in and out a couple of times, and I'm reinforcing for them how they're going to get these mild symptoms. They're going to get better over time, but keep taking their therapy. And any educational materials, and there's all kinds on the websites. You can find them to reinforce the messages you're having. All right. So again, how they do this, it's going to be in a foil pouch. Take the tablet out. It's stored at room temperature. You don't open it before you use it. You don't want it to get all moist beforehand. You put it under the tongue. It'll dissolve within 10 seconds. Under the tongue, I mentioned. You wash your hands after handling a tablet, because otherwise you got antigen potentially on the tablet. If you rub your eyes and so on, it might cause some itchy eyes. You don't want to swallow for a minute if you can help it, because you want it to stay under the tongue. And you don't want to eat or drink for 5 minutes after taking the tablet. Not for an hour, just for 5 minutes, because you don't want to wash away. You want to leave as much there as possible for the continued response and the continued antigen presenting cells' ability to reach it. So if you miss a dose, take it the next day. If you miss a week, then you may want to talk to the doc. And depending on where you are in the process, I might want to see them for that next dose, because they're a little more likely to have a reaction, because that conversion from IgE to IgG has stopped a little bit, and they're more likely to have an IgG response there. All right, so what about safety? So the likelihood is much smaller for sublingual than subcutaneous, and it's practically zero for sublingual, but nothing zero. There's been about 11 cases of anaphylaxis reported for the World Asthma Organization criteria out of 1 billion doses given since 2000, and they were all non-fatal. So very important. Even if they have anaphylaxis, they were non-fatal. 2.7 reactions per 1,000 doses, and a very small level, were actually classified as severe. That's less than 1%. Okay, less than 1 in 1,000, as you can see, or 5 in 1,000, and severe. And severe also included abdominal pain and vomiting. But what's a little bit more common is some facial swelling and some swelling of the uvula. So just a little hint: have a look at the uvula before you start, so you have an idea how big it was before. Because if they get some throat discomfort, you have a look inside afterwards, you may not realize that it's actually gotten bigger. And then you can give an antihistamine. In fact, there's even some studies that have talked about giving an antihistamine prior to the first few doses of sublingual therapy. That's got mixed reactions so far as well. But if you have someone who's really anxious, you might want to think about doing that. Most of them are local, which I'll show you some pictures of. They're mild, and they go up in the build-up phase. So as you're starting the therapy, and it's in the first number of weeks is really when it's there. And again, those GI symptoms can happen, especially the stuff they've swallowed. And then the concern I have, and the reason I threw this in, is because people get afraid of these reactions. It's really important to reinforce them and contact them again maybe a week later and say, they're getting better, aren't they? Like I told you. Okay, because otherwise they may stop the therapy. And you've gone to all this trouble to get them started on this. You've learned a new skill to do this just for them to stop it. That's such a shame. So we need to reinforce. So call them, have your staff call them, make sure there's no issues, and deal with that kind of thing. That makes a huge difference. So common side effects. And again, this is subtle, but you can see the sublingual edema that's occurred here, right, with the sublingual therapy. This is a little worse. They have swelling of the lip. This is going to make people a little bit more nervous. This is much less likely to occur than sublingual swelling, but it can occur. Okay? And then you get that symptom of just the throat feeling tight. And obviously you're paying a lot of attention to that. You're having a look in the throat. You're making sure they're okay. You may want to throw an oximeter on them if this is happening. Just make sure they're okay. At the end of the day, this stuff's going to go away, and you're going to end up with someone who's happy, who can breathe, who's not going to have a big issue. Now, they're very, very transient, and they go away. So if you look over days, the biggest number happened in the first day, and over the first few days, it's virtually there. So over the first week or 2 weeks, and after the first couple of weeks, they are pretty well gone. It's unusual to happen. And if it's happening beyond the first few weeks, probably they haven't been regularly consistently adherent. So you can gently ask that question to find out why. If they're calling, say, well, I'm still having tingling, I'm still having this. Don't ignore that. You have to think about that. If they're having reactions, and of course, having a very significant reaction, you're going to talk about that. But overall, they're very transient for the most part. Now, I want to point out that we're not talking about sublingual therapy. These are not FDA approved. They're being used more in Europe. They're being used more in the States. They're all off label. They're kind of interesting because we can do all kinds of interesting things with them that we don't have sublingual therapies for right now. So they're an exciting thing there, but I don't have much evidence for them. That's the problem with them. So right now, if those of you are thinking, well, I'm going to use sublingual allergy drops because I have somebody pushing them at me to use them, I would recommend, and I don't use sublingual drops. I only use the drugs that are made, as I mentioned right now. So again, my algorithm here, because I really want to hear from you, both now as well as in the post-evaluation, if you think that this made sense to you and you think you could incorporate this in your practice. Your patients have symptoms. They don't have red flags. You've had treatments and they're not doing as well as you want. You define whether they're seasonal or allergic, seasonal or perennial. If they're asthma, they're reasonably well controlled. You confirm if they've had testing. If they haven't had testing, you do it yourself. And then you go ahead and you prescribe sublingual immunotherapy for the appropriate immunotherapy. And then once you do that, you review them and you see how they're doing. You review them at least annually. Remember, you're giving a lot of reinforcement in this initial period because they're going to have some nuisance local side effects for you to reassure through. So thank you so much for your attention. I hope you're feeling empowered to do this. Here's the Family Physician Airways Group of Canada website. Here's my personal email. If you want to send me an email or a question about this, please go ahead and have a look at the FPAGC website and feel free to join up. It doesn't cost anything. As I mentioned to you, we'd love to have more colleagues. At the end of the day, what do we want? We want our patients that look sort of like this to then look like this and be happy. And I hope that's going to be something that we can do in our practice. And I hope I've given you a mechanism to that easily in your practice. Marco, I'll give it back to you.
Excellent. Thank you, Alan. I would like, you mentioned something that also Dr. Frank mentioned, and it was part in the mix with the pathophysiology that Dr. Kamisha Wright mentioned. I want to bring Dr. Kamisha back for the quick perspective. Because I'm starting to make this self question. So everyone emphasizing that we cannot just leave this as it is. We need to treat it on time. There's some implications in terms of the physiology of the respiratory tree that there's might be long-term changes that are not that positive for the patient if we do not start these kind of therapies on time. So I want to hear a little bit about what Dr. Wright has to say, and then we go back with Dr. Allen to expand on how I go through these algorithm, because I think many of us still want to get more insight on that. Dr. Wright, please.
Yeah, I mean, that's a very valid point. I mean, typically, like when we talked about the unified airway with like, nasal congestion and the effects on like the lungs and the bronchus and things like that. Typically what we see is that when you have inflammation, like allergic rhinitis, and you get, inflammation in your nasal mucosa, we know that you can also have some of those inflammatory cytokines, or we hypothesize that those cytokines are going to be released in the entire body. We see effects not only in the nasal cavity, but also in the chest as well. And one of the effects, if it's not treated, could relate to actual like changes where the architecture of the actual lung, is changed. The basement membrane can thicken. The smooth muscles can also like enlarge. You can have fibrosis that occurs that can become irreversible, and they could lose their, lung function, long term. And those things could be irreversible, where if we treated them early, like, with the steroids we talked about, immunotherapy, things to try and like prevent this from getting to an irreversible state, it'll be greatly beneficial.
Excellent. Thank you for that perspective. Usually efficacy of treatments, it's basically measured these three ways, or we determine whether or not this is effective as a treatment. So the number one thing is we're looking, patients are living longer. So these are not life-threatening allergies, but they do change the quality of life. So the second thing I'm looking for is, but you're feeling better. And that is more a subjective experience. And then comes the third one. Are they functioning better? Are they breathing through their nose and so on? And I'm going to switch it back to Dr. Allen because he was during his presentation. Thank you, Dr. Wright. He has presented the algorithm. He was saying, hey, we need to measure these things. We need to make sure, oh, are you feeling better? But that's one. And then, are you functioning better? Can you go and expand a little bit on what tools you recommend to measure symptoms and track them as you progress in your treatment?
Well, there's lots of them, and earlier on, total nasal symptom score and the SNOT scores were all mentioned as allergic rhinitis tools. You can actually mention and see. I showed you the RCAT, which is a fairly simple tool with many less questions than the SNOT 22, which has 22 questions, and so on. That's there. Fatigue is a much. There are tools for fatigue that you could use as well. You could also measure some of the tools related to mood, because that tends to be a factor as well for that. So there's a number of things. It's sort of the global gestalt of the patient on all those different levels. You can use that. Your patients are generally going to have a pretty good idea. I'm not so tired anymore. I'm more functional. That a tool for that I don't have readily to describe to you in terms of functionality, but there are fatigue tools that are out there. I want to come back to the earlier administration. Kamisha commented on, and a couple of things. There's no question that earlier treatment is going to prevent disease elsewhere and prevent the continued progression of the illness, right? We want to change the body from that. Wade Watson, who's a pediatric allergist, did a study years ago where he people with allergic rhinitis and asthma, and he treated the nose, but he put a block way up high, so the nasal steroids couldn't go any further. And by treating the nose independently, it also treated the asthma. It decreases bronchial hyperactivity. And similarly, if you treat the asthma, it decreases allergic rhinitis score, even if you don't treat the nose. So it's a very, as Kamisha said, it's a systemic effect. It's a bone marrow effect. Eosinophils are created in the bone marrow, cytokines affect in the bone marrow. So it's a total body effect. And that's how this modifies the entire system. And there's a new concept that's coming out now in asthma called remission. You're going to hear more and more about the concept of remission. And the idea of remission is in people with asthma, actually getting them so that they can be symptom-free, not need to use beta agonists, no longer need oral steroids ever, and then have even improvement in lung function. And we're seeing that more with the use of biologics, which are expensive, of course, but the concept is there. And immunotherapy has a concept to be able to do that. I showed you the ability to take some people right off all their medicines. So with that, it's sort of so exciting that how do we not jump onto this and not get more excited? I think part of it's because it's always seemed to be something we don't understand, and with speakers like you've had today to explain the whole system so clearly and giving you a way to do this easily in your office, we can actually do this easier and better. So
excellent. So yeah, in understanding, like the late Marie Curie used to say, I'm going to try to quote her as the best to my knowledge, but things are not to be feared, but to be understood. That's why we're here. We need to understand these mechanisms. And also, Dr. Fran mentioned something earlier today, and you were emphasizing that, yes, we need to be prepared for the worst in terms of an anaphylactic shock, but it's happening 1 in 10 million doses. So that's a very limited rate. So there is the possibility that that can happen, but it's a very remote possibility. But if that one is your patient, you want to be ready. You want to get set. And perhaps that is a great point to transition into our next talk.